Hello, everyone. So let's continue with this a series of chapter regarding hormone drugs. We're gonna review drugs that substitute block hormones from the hypothalamus and pituitary drug. So let me share my screen. Okay, so regarding this chapter, hypothalamus, pituitary gland, those are the hypothalamus is the part of the brain that, in conjunction with the pituitary gland, the master gland, regulate all hormones that affect the body since birth until death. Here we're gonna just mention the hormones. From the anterior pituitary gland, we have the growth hormone, corticotropin, thyrotropin, follicle-stimulating hormone, luteinizing hormone, prolactin. From the posterior pituitary gland, we have oxytocin and antidiuretic hormone. So in this chapter, we'll only emphasize just a few of them. We have other chapters where we'll emphasize the other hormones, like thyrotropin, already mentioned on the thyroid chapter. So we're gonna start with a growth hormone. So, like the name says, promotes growth, promotes synthesis of protein to make new tissue, and promotes carbohydrate metabolism. In other words, growth hormone works hand in hand with insulin. That's very important to remember. Growth hormone and insulin works hand in hand. Now, what happens with growth hormone? What diseases do we have when we have a deficiency? Well, dwarfism. We have a dwarf. And when we have too much, we can call it gigantism, 7 to 9 feet tall, or acromegaly when this happens when the patient is an adult. So let me see if I can share some pictures with you. Let me see. See if I can jump from here to here, and we're gonna put here gigantism. So this is very, very obvious. Here we have here one of the tallest men in the world. And the reason they get this big is because the pituitary gland, when he was a kid, he developed a tumor. Again, the age is key. When this tumor happened, when the patient is a kid, we're going to have gigantism. As you can see with him, same person. See, we have better ones. Okay. I forgot the name of this NBA player from China. He had gigantism, and the reason he stopped playing is because, unfortunately, yeah, they're very tall, but the bones are too brittle. So it's very easy for them to have fractures from nowhere. It's very hard for them to move, and this thing was happening to this NBA player. He noticed that, you know what, my performance is not the same. I started to have bone pain, microfractures, and that's when he retired. So gigantism is a tumor in the pituitary gland with too much growth hormone being released. And again, this happens in kids. Now, what happens when the tumor happens on a patient that is already an adult. I'm gonna call them acromegaly. Let me find a good picture here. Well, we have the Great Khali, Andre the Giant, but I like this picture over here. This is a series of pictures and different stages of the life of this patient. You know, when he's an adult and when he's middle age, 40 years of age. And, you know, you have to consider that during this time, uh, pictures were not taken often as we do selfies nowadays. So you can see right here, he looks normal, develops that tumor. He's already an adult, but instead of getting bigger, soft tissue starts to overgrow. You can start seeing changes on the nose, the chin, ears, lips. So we jump all the way over here. Yeah, you can see that the nose is bigger. First picture. We can see changes on the size of the ears, the lips, the jaw, and this is a very characteristic face on acromegaly. Uh, let's put Andre the Giant. Okay, this picture right here. So Andre the Giant developed this tumor when he was in early adolescence, early teens. So he started to grow very, very fast, undiagnosed. And then when the bones fuse and bones start growing, that's when the facial features started to change. Yeah, you can see the nose, the jaw, the ears. Great, the great Kali. You can see he also has changes on the nose, on the jaw, ears, soft tissue. The hands also they become very big. Feet. So anything that a soft tissue is gonna grow. So that's acromegaly, very different from gigantism, and all that is based on when this tumor happened, kid or adult. Okay, let's go back to the PowerPoint. And we mentioned the lack of growth hormone is dwarfism. So when the patient has this problem of dwarfism, obviously the going to provide growth hormone to the patient. The adverse effects is hyperglycemia. We mentioned growth hormone and insulin work hand in hand. In this case, we're going to have hyperglycemia. Unfortunately, uh, neutralizing the antibodies because most of the energy goes to bone formation instead of the bone marrow. The growth is so fast that we may see carpal tunnel syndrome on the patient's wrist. And in conditions of Prader-Willi syndrome, it can be fatal. If for some reason growth hormone doesn't work, we can provide a medication that is very similar to insulin, and we call it insulin-like growth factor 1, which the medication is mecosermin, Increlex, and this medication is used only when growth hormone, the treatment of growth hormone doesn't work. Again, keyword insulin, so the adverse effects going to be hypoglycemias. So we need to tell this patient that, hey, you know, careful, or the parents of this patient, usually their kids, to monitor glucose levels. Other than that, intracranial hypertension, arthralgias, all that happens now because the bones are starting to grow a little bit faster than what is expected, what patient is used to. So that's going to produce pain. If we're not careful on the treatment of the patient, we're going to have overgrowth of fat, facial bones. They're going to look like they have acromegaly. I know, but this is a patient that is short. Now, regarding acromegaly, now jumping from dwarfism to gigantism, acromegaly, the treatment is surgery. We need to remove that tumor. Patients, this is another patient, Andre the giant, no, not Andre the giant, the Big Show. The Big Show, same thing, just like Andre the giant and the Great Khali. He had this tumor, but he was actually diagnosed when he was 16, 17 years of age. So we don't see those changes in the face. Yeah, he was a football player, almost 7 feet tall, very big. And the coach was the one that told him, hey, you know what, you need to get yourself checked. You're way too big. So they went and a doctor, they did a mammography study, and they noticed, yeah, you have a tumor. We need to remove it. So for gigantism, acromegaly, the definite treatment is surgery and obviously radiation before the surgery. Try to eliminate as much of the tumor as we can without being invasive. And somatostatin, this is the drug that we give to the patients in order to prep them to surgery. And the less invasive we are, the smaller the tumor, by the time we get to the surgery, the better the outcome. So somatostatin is an analog or is similar to octreotide and lanreotide over here. These two are used for carcinoid syndromes. So right here for carcinoid syndromes. So somatostatins, they suppress the release of growth hormone. The medication can be intramuscular or sub-Q. And again, somatotropin is not the definite treatment. Somatostatin, sorry. Somatostatin is not the definite treatment. We start to give them in order to suppress the size of the tumor. We can use radiation, but the last procedure that we do is always going to be surgery. Need to remove that tumor. Another hormone that we may lose control is prolactin, pro in favor lactin breast milk. Prolactin is very high after delivery of the baby and the pregnant patient. That's when it's normal. Unfortunately, sometimes due to drugs, stress, infections, tumors, we can have a hypersecretion of prolactin. And in the female patient, we're going to have amenorrhea, lack of menstrual cycle. And again, try to connect all this. I mentioned that prolactin is released, or we see it commonly from breastfeeding. And usually during that time, there's no menstrual cycle. And usually it's around 3 months where prolactin is able to inhibit the menstrual cycle. So it makes sense that a patient, female patient, that for some reason is making too much prolactin is going to go into an amenorrhea state, lack of menses. So if there's no menstrual cycle, there's patients going to be considered infertile. Again, there's no cycle, there's no ovulation. If the patient is a young patient, 6 years of age, purity is going to be delayed. Galactorrhea, this is the term that we use for the production of breast milk under abnormal conditions. In this case, the patient has never been pregnant, but is making breast milk. So we call it galactorrhea. In the male patient, gonna have a reduced libido and potency. Sex drive goes down. Also, they're gonna have galactorrhea, and if the patient is too young, they're gonna have a delay on puberty, just like in girls. In this case, it's a boys. We didn't mention this drug, bromocriptine. We mentioned it in Parkinson's disease because it's able to stimulate dopamine, but also blocks prolactin. So with bromocriptine, you have to be careful regarding the adverse effects. So in this case, bromocriptine is used to block prolactin. And we didn't mention, bromocriptine is used to stimulate dopamine. Just based on that are the adverse effects. Dopamine belongs to the sympathetic nervous system. So I'm gonna have stimulation of the heart. So patients taking bromocriptine with oversecretion of prolactin, the adverse effects have to do with tachycardias, chest pains, palpitations, and so on, overstimulation of the heart. So that would be with prolactin. Another hormone, this is from the posterior portion of the pituitary gland, antidiuretic hormone, or ADH, antidiuretic hormone. So this hormone, the normal function is to block the production of urine. ADH retains water. So what electrolyte is related to water? Sodium. So don't forget that water and sodium are always related. They go together everywhere. So now let's see what happens when there's no antidiuretic hormone. So we mentioned antidiuretic hormone, the function is to block the production of urine. So if the patient is not making ADH, it's gonna urine too much. It's gonna lose a lot of fluids, urine. We call that diabetes insipidus, diabetes without flavor. That's what the term means. And this is a story. Diabetes mellitus was diagnosed on 3 symptoms I already mentioned, where they have polyuria, too much urine, polydipsia, too much drinking water, polyphagia, eating too much. So diabetes insipidus share 2 out of 3 symptoms. We have the polyuria. This patient is urinating a lot because there's no ADH, so they're urinating a lot. That's producing dehydration. And also, they're drinking too much water. This is a patient that is peeing 10 to 20 liters of water per day at least. Usually the bladder, when it's really full, is half a liter, the most. And this patient is peeing liters per day. So we have those two. Too much peeing, obviously too much drinking water. Back in the day, before having proper labs, basically the doctor will ask the patient, hey, can you provide a sample of urine? So they'll provide a sample, they'll smell it, and they'll have this apple smell. And then, a little drink of the urine, spit it out, and it will have this apple aftertaste, like cider aftertaste. So back in the days, that's how they used to identify diabetes mellitus, tasting and smelling the urine. With diabetes insipidus, like to you, it means no flavor. Insipidus, no flavor. They will smell the urine, and there was no apple odor characteristic, nor fruity odor. Some authors use the word fruity. And they will taste it, and it was tasteless, insipidus. So the lack of ADH is going to produce diabetes insipidus. This patient is going to make too much urine. It's gonna use a lot of fluids. Also, ADH is used for patients that have a problem of bedwetting. Same thing. During the night, they pee in their beds. And this kid, they can range from 5 years of age to 50 years of age. So I'm gonna give ADH. I'm gonna block the production of urine. So in the morning, the bed is not wet. The presentation of ADH is called desmopressin. That's the drug name of this hormone. Desmopressin, vasopressin. We'll see that later. Also is used on patients with bleeding disorders. ADH, besides blocking the production of urine, can stimulate the stimulation of receptors to make blood clots. So hemophilia A, it helps by stimulating the clot factors. And with von Willebrand, they stimulate the platelets to start the process of a blood clot. So real quick, every time we have a bleeding and we make a blood clot, the first part is platelets, the second part is clot factors. So if the patient has von Willebrand disease, we can give desmopressin to stimulate the platelets and make that start the process of blood clot. Or if the problem is hemophilia A, then we can also give desmopressin to finish the process of the blood clot. So vasopressin, this is the other presentation of ADH, desmopressin, vasopressin. Now, what happens when I stimulate the production of ADH, or when I give a medication that is similar to ADH? Well, now I'm gonna retain water, and that's gonna give me water intoxication. My cells are gonna drown. Neurons, they're gonna engorge on how much water is on the environment, that they engorge and they stop working. Now, let's go the other way. Now, for some reason, the patient is making too much ADH. So that means that they're retaining water, hypervolemia. Usually this happens after trauma, head trauma. ADH problems where the pituitary gland starts making too much of it, usually is secondary to trauma. So this patient goes to trauma, I don't know, car accident, hit to the head, baseball bat, something like that, and they start making too much ADH. So that means that they're gonna start retaining water. And by retaining water, they're gonna do a dilution effect with sodium, too much water, not enough sodium. We call that hyponatremia. So what is the problem with that? With this? Water intoxication. If I retain too much water and dilutes the sodium, all that water is gonna go to every tissue, it's gonna go to every cell, so they're gonna engorge and they're gonna start functioning. So I'm gonna provide canivapan to make that patient pee, block the function of an ADH, so the patient can pee and lose that water. The only thing I have to make sure is to follow sodium levels and prevent hypernatremia. Again, too much sodium. Now we're going the other way. Now, gonna produce dehydration effect. If I lose too much water, I'm gonna have a hydration effect. The cells, instead of engorge, now they're gonna shrink. Hypernatremia produces seizures. The other medication called Vaptan. So we have Vaptan and Vaptan use another medications that block the functions of ADH. And the last one is oxytocin. This one is used during uterine contractions and labor, and this is to help push the baby out. Usually conditions where the patient doesn't make oxytocin, they're very, very rare. But oxytocin is used a lot in labor. And it's just to help the mom push the baby faster. Usually new moms, it can take up to 24 hours to deliver a baby. So it means 24 hours of pain during labor. So we provide oxytocin. We increase the levels of oxytocin that the mom already has, and we help that mom push that baby out and reduce the time frame of the mom being in labor. And oxytocin is also used, or not used, sorry, it's also secreted from the pituitary gland during breastfeeding. So oxytocin goes to the gland and squeezes the tubes in order to push that breast milk out of the nipple for the baby to be able to ingest it. The name of oxytocin, pinotocin. That's the name that you're gonna hear labor and delivery. For pinotocin on the patient. Basically, it's synthetic oxytocin. Okay, that will be the whole chapter, very short chapter, and I'll see you on the next one.